అయిందా
చూపిస్తాను సార్ మీకు
చూపిస్తాను మళ్ళీ అయిన తర్వాత మళ్ళీ అవ్వలేదంటారు రెండు సార్లు అయిందా సరే థ్యాంక్ యూ So good morning everybody. Today we are going to discuss regarding peripheral nerve injuries. Peripheral nerve injuries. Coming to anatomy, peripheral nerves. This is the structure of the peripheral nerve where you can see that so many muscle fibers are there. They are arranged in bundles which are called fascicles. Fascicles. Each fiber is surrounded by a structure called the endoneurium. Each fascicle by a perineurium, and all the fascicles are enclosed in a connective tissue which is called epineurium. Okay, so peripheral nerves. What are peripheral nerves? Peripheral nerves are bundle of axons conducting the efferent impulses from the cell in the anterior horn of the spinal cord to muscles, and afferent impulses from the peripheral receptors via the cells in the posterior dorsal root ganglia to the cord. All the motor axons and sensory axons are coated with myelin sheath, interrupted at the nodes of Ranvier. You can see the outside Schwann cells. The axon is covered by connective tissue called the endoneurium. The axons that make up the nerve are separated in bundles. Several axons are enclosed in bundles, which are each and every bundle of bundles of fascicles are surrounded by perineurium. You can see here these are the fibers which are surround. Each and every fiber has endoneurium. This is a fascicle which has so many. Fascicle is surrounded by perineurium, and all the fascicles are enclosed within a connective tissue covering called the epineurium. Okay. Sensory innervation of the limb. Area of hypoesthesia is due to nerve injury may be less than the area of skin supplied by that nerve because of the overlap of sensory supply. See, the sensory innervation of the hand has actually 3 zones. One is autonomous zone, 2 is intermediate zone, 3 is maximal zone. So autonomous zone, intermediate zone, and maximal zone. Autonomous zone is an area which is supplied exclusively by the nerve. Is called the autonomous zone. Intermediate zone is an area which is overlapped by the other nerve also, and the maximum area a nerve can supply is called the maximal zone. Okay, so if there is a nerve injury, there is complete loss of sensation in the autonomous zone, because the autonomous zone is a zone which is exclusively supplied by the peripheral nerve, sensory nerve. Okay, so these zones are found in all nerve injuries. The autonomous zone is a relatively smaller area of complete anesthesia. Why? Because this autonomous zone is a zone which is supplied exclusively by the sensory nerve. So motor innervation of the limb. You can see here, this is the sensory innervation. The medial 1.5 fingers of the hand are supplied by the ulnar nerve. The lateral 3.5 fingers are supplied by the median nerve. This part is supplied by the radial nerve. Okay, this part is supplied by the radial nerve. On the dorsum, medial 2.5 is supplied by ulnar nerve. Lateral 2.5 is supplied by the radial nerve, but the proximal distal phalanges are supplied exclusively by the median nerve. of the second and third digits, the proximal and distal phalanges are supplied exclusively by the median nerve. Motor innervation of the limb. Early for the diagnosis of the nerve injury, the points to be remembered are: 1. For the diagnosis of any nerve injury, so what is the nerve supply of any particular muscle, the different muscles which are supplied by the nerve, and the action of the muscle, and by what maneuver can we appreciate the action. So anatomical features relevant to nerve injuries. So relation to surface, superficial nerves are more prone to injury by the external object like the median nerve in the wrist. In relation to the bone, radial nerve injury is more common in shaft of humerus fractures because the radial nerve is in close proximity to the humerus in the spiral groove. In relation to fibrous septa, like in the case of distal third humerus fracture, the radial nerve, which is in close proximity to the lateral supracondylar ridge of the humerus, because of the tight lateral intermuscular septum, that nerve may get entrapped in the septae. So relation to major vessels and cores in the confined space, like median nerve in carpal tunnel, median nerve for compression in carpal tunnel. So now coming to pathology, so degeneration and regeneration. So whenever there is a nerve injury, like here, the distal part of the nerve, undergoes Wallerian degeneration. Distal part of the nerve undergoes Wallerian degeneration. Also, the proximal end also undergoes Wallerian degeneration till the first node of Ranvier. You can see here that this is the node of Ranvier. So distal part completely undergoes Wallerian degeneration, but the proximal part also undergoes Wallerian degeneration till the first node of Ranvier. Okay. So what happens after this? There is Wallerian degeneration. The Schwann cells slowly proliferate. Giving rise to numerous nerve filaments, axons, and if they find their endoneural tubes or the perineural tubes, then the nerve grows and reaches its motor end plate in the muscle. Okay. So this is Wallerian degeneration and regeneration. So mechanism of injury. Injury, dislocation, it is most common. Thermal injury, cut, laceration, electrical injury, infection, ischemic injury, compression, traction, friction, toxic agents, and cooling and freezing and radiation. Coming to classification of nerve injuries, there are so many classifications. One is Seddon's classification, two Sunderland's classification. So one is transient ischemia. Two, it is neuropraxia. Three, axonotempsis. Four, neurontempsis. Seddon's classification. Coming to transient ischemia. So due to transient endoneural anoxia. So whenever there is a compression on the nerve or due to traction of the nerve, there is transient ischemia to the nerve. There is blood supply to the nerve is not there for some period of time. So that is because of transient endoneural anoxia due to acute nerve compression. This transient ischemia is a reversible condition. So within 15 minutes there is numbness and tingling. After half an hour there is loss of pain sensibility. After 45 minutes, there is muscle weakness. Relief of compression is followed by, so when the compression is released, it is followed by intense paresthesia up to 5 minutes, and the feeling is restored within 30 seconds, and the full muscle power after 10 minutes. Okay, so this is transient ischemia. In transient ischemia, all the muscles, all the nerves, they recover simultaneously. Now coming to neuropraxia. So neuropraxia is a reversible physiological nerve conduction block. That means the conduction, the nerve is anatomically intact. The nerve axon is anatomically intact, but the conduction through the nerve is gone. So it is reversible. So it is called reversible physiological nerve conduction block, in which there is loss of some types of sensation and muscle power, followed by spontaneous recovery after a few days or weeks, around 6 weeks to 6 months. So neuropraxia, there is reversible physiological nerve conduction block. Okay, so it occurs because of mechanical pressure causing segmental demyelination. So what happens is, in neuropraxia, because of traction injuries or compression of the nerve, there is segmental demyelination. So segmental demyelination. So that's why there is conduction block. Conduction block. Okay, it can be seen in crutch palsy and tourniquet palsy. Now coming to axonotempsis. Axonotempsis is anatomical interruption of the axon. That means the axon is completely severed, but the endoneural tube which encloses the nerve fiber is intact. The endoneural tube which encloses the nerve fiber is intact, but the axon is divided. So there is loss of conduction, but the neural tubes are intact. Now what happens in axonotempsis is this Wallerian degeneration. That means the distal part of the nerve, axon, it undergoes Wallerian degeneration, and also the proximal part of the nerve till the first node of Ranvier. It undergoes Wallerian degeneration. So axonal regeneration occurs within hours of nerve damage. So what happens is, after there is degeneration, these endoneural tubes are still intact. Endoneural tube is intact, but the axon is disintegrated. So what happens is, from the proximal end, the Schwann cells proliferate. They give rise to numerous nerve filaments which travel through these endoneural tube, and they slowly reach the motor end plate at the rate of 1 mm to 1.5 mm per day. So the nerve regenerates at the rate of 1 mm to 1.5 mm per day to reach the motor end plate. Okay, so what happens is, whenever there is axonal regeneration, there is no simultaneous myelination. This myelination, it starts a little later. So what happens is, not all the regenerating nerve is covered by myelin sheath. The early regenerating nerve is not covered by myelin sheath, and slowly the myelin sheath covers the later. Myelin sheath is covering the regenerated nerve later. So what happens is, the recently regenerating axon is not covered by myelin sheath. So whenever you tap on the regenerating nerve, it gives rise to some sensation along the course of the nerve, which is called Tinel's sign. Okay. So when the nerve regenerates, at the rate of 1 mm to 2 mm per day through these endoneural tubes, so this nerve slowly, stepwise, it innervates the muscles on the way it innervates the muscles, so which gives rise to motor march. So in axonotemsis there is motor march and Tinel's sign. In neuropraxia, because all the muscles they regenerate simultaneously, all the muscles they are innervated simultaneously, there is no motor march or Tinel's sign. Now coming to neurontemsis. Neurontemsis is complete division of the nerve fiber along with the endoneural tubes. There is rapid Wallerian degeneration of the distal part of the nerve and also the proximal part of the nerve till the first node of Ranvier. So whenever there is a complete division of the nerve, because there are no endoneural tubes, the Schwann cells proliferate in a disorganized fashion, giving rise to a small mass of newly proliferated axons, giving rise to a neuroma. Okay, neuroma. In neuroanatomsis, this surgical repair is essential. The function after neuroanatomsis is adequate, but it is never normal. It is never normal. So now you can see here that these are the grades of nerve injury. So this is transient ischemia, where the nerve is intact, anatomically intact. Here you can see that the conduction block is there. Here the axon is completely divided, but the endoneural tube is intact. This is axonotemsis. Here there is severing of the nerve. The endoneural tube is also cut. This is neuroanatomsis. So now coming to Sunderland's classification. Sunderland classification is classified the nerve injuries into 5 types. So one is focal conduction block. There is no Wallerian degeneration. Type 2, there is axonotemsis. Type 3, it is axonotemsis, axon plus endoneurium also disrupted. Type 4, it is endoneurium plus perineurium disrupted. Type 5, it is endoneurium, perineurium and epineurium disruption. So type 1, it is neuropraxia. Type 5, it is neuroanatomsis. So type 2, 3 and 4, it is axonotemsis. So diagnosis of any peripheral nerve injury depends primarily on the precise history and exact clinical examination. So history, patient complains of weakness of the limb, inability to move the limb, there is numbness. The cause may or may not be obvious. So when the cause is obvious, the nerve affected can be easy and its level can be easy to diagnose. When the cause is not obvious, the history of any injection in the nerve, any medical causes like leprosy, diabetes should be asked. On examination, there is typical attitude and deformity. For suppose if there is a wrist drop, it is radial nerve palsy. If there is a foot drop, it is common peroneal nerve palsy. For suppose if it's winging of scapula, it is serratus anterior long thoracic nerve palsy. If there is claw hand, it is ulnar nerve palsy. Ape hand deformity, median nerve palsy. Pointing index, median nerve palsy. Policeman deformity, brachial plexus palsy. So wasting of muscles will become obvious sometime after paralysis. So wasting of muscles is because of disuse atrophy. So disuse atrophy, because the muscles are not innervated by the nerve. So because of disuse atrophy, these muscles go into wasting. Comparison with the opposite sound side. You should always compare the wasting with the normal extremity. Skin becomes dry, glossy and smooth because of trophic changes. The skin becomes dry because of loss of sweating, glossy and smooth, pallor and cyanosis is present. The trophic changes can be their brittle nails, skin becomes atrophic, shiny. Okay, so temperature of the extremity is cooler and drier, it is dry. Sensory examination, different forms of sensation to be tested in a suspected case of nerve palsy. Sweat test to detect any sympathetic function in the skin supplied by the nerve. Presence of sweating within an autonomous zone of the injured peripheral nerve reassures that the complete interruption of the nerve has not occurred, which is called starch test or ninhydrin test. So motor examination, what we do is motor examination, we try to examine for the individual muscle and try to clinically examine for the power in the muscle. So regional survey of nerve injuries, brachial plexus injuries, most commonly it is the Erb's palsy or the upper brachial plexus palsy, Klumpke's palsy or the lower brachial plexus palsy. Erb's palsy is injury to the C5, C6 and C7. It is common in overweight babies and in patients in shoulder dystocia at delivery. The abductors and external rotators of the shoulder and supinators are paralyzed, giving rise to a typical deformity which is called policeman receiving the tip deformity, which is arm held by the side of the chest, elbow extended, forearm completely pronated, wrist flexed. This is the Erb's palsy. This is the typical deformity which is called the policeman receiving the tip deformity. Now coming to Klumpke's palsy. Klumpke's palsy is injury to C8 and T1. Usually it is after a breech delivery of smaller babies. Baby lies with the arm supinated and elbow flexed. There is loss of intrinsic muscles of the hand, which is the intrinsic minus hand. So intrinsic minus hand is a claw hand. Okay, there is also in Klumpke's palsy there can be a associated Horner syndrome. Horner syndrome is ptosis, meiosis, anhidrosis and loss of ciliospinal reflex. So this is the typical deformity of Klumpke's paralysis. Now coming to long thoracic nerve. Long thoracic nerve is from the roots C5, C6, C7. It is directly from the roots. The long thoracic nerve is a nerve which is formed directly from the roots of C5, 6, 7. It supplies the serratus anterior muscle. The injury causes paralysis of the muscle, causing winging of scapula and complaint of aching and weakness on lifting the arm. It is tested by pushing the extremity against the wall. What will happen is the side of the scapula, the medial border and the inferior border of the scapula, they stand prominent when the patient attempts to push the extremity against the wall. Okay, here you can see that this is the winging of the scapula, where the medial border of the scapula and the inferior border of the scapula, they stand prominent. Now coming to spinal accessory nerve. Spinal accessory nerve has a root value C2 to C6. Spinal accessory nerve is formed from the posterior primary rami of the C2 to C6 rootlets. They supply the trapezius muscle and also the sternocleidomastoid muscle. So injury causes severe pain and stiffness of the shoulder, reduced ability to hitch and hunch the shoulder. There is mild winging of the scapula. In trapezius palsy, there is a pseudo winging of scapula, pseudo winging, okay, that disappears on flexion, and there is forward thrust of the shoulder. So this is the spinal accessory nerve injury where the patient may not be able to shrug the shoulder. Patient may not be able to shrug the shoulder. Now coming to axillary nerve injury, the root value is C5, C6. It supplies the deltoid and teres minor muscle. Cutaneous branch supplies the skin over the lower half of the deltoid, which is called the regimental badge area. Regimental badge area. The injury caused is shoulder weakness and wasting of the deltoid muscles. The abduction can be initiated, but it cannot be maintained. The extension of the shoulder with the arm abducted to 90 degree. Arm abducted to 90 degree is lost. The small area of numbness which is there, which is called the regimental badge area, or the surgeon's patch sign, or regimental badge sign. So test it is stabilize the scapula with one hand while the other hand is kept over the deltoid to feel for its contraction. Patient is asked to abduct the shoulder, and inability to abduct the shoulder and the absence of deltoid paralysis. The individual nerve injuries like the radial nerve, median nerve, and the ulnar nerve we can discuss in the we can discuss next week. Okay, thank you.